moment. So we'd like to welcome everybody to this academic and brilliant academic lecture on lipid management. So I would like to welcome Professor Raman Puri. He has joined from India, and he is the president of Lipid Association of India. And we would like to welcome Professor Ridwanur Rahman sir. He is the ex-professor of Sohrawardi Medical College, and he is one of the pioneer clinical researcher of Bangladesh. And Dr. Nazmul Hassan is a young cardiologist, and he is the youngest fellow of European Society of Cardiology. So I would like to welcome all the guests here and all the participants. So we can start our session. And today's session will be, there will be one lecture, and this lecture will be provided by Professor Raman Puri, and this will be about 40 to 45 minutes duration. That will be followed by a question and answer session. That question and answer session will persist about 20 to 25 minutes, around 15 to 20 minutes, and that will be followed by the comments of our Honorable guest Professor Ridwanur Rahman sir and Dr. Nazmul Hassan. So before starting our session, I want to share a little biography of Professor Raman Puri. Sir, we know that Professor Raman Puri, he is one of the pioneer of lipid research of India and in the South Asian region, and also in the field of lipidology in the world. Professor Raman Puri, he has done his MBBS in 1976 from Maulana Azad Medical College in New Delhi in 1976, and he has done in MD in Internal Medicine from Safdar Hospital in 1983, followed by DM in Cardiology in 1991. He was the ex-professor of medicine in Lady Hardinge Medical College of New Delhi. Now he is working as a senior interventional consultant cardiologist in Indrapasha Apollo Hospital, New Delhi. He has co-authored many original articles and publications, and he also authored a chapter in a textbook. He is the founder chairman of Lipid Association of India, and he has published, and Lipid Association of India has published 3 expert consensus guidelines or statement since 2016, part 1, 2, and 3. And now we come to Professor Ridwanur Rahman sir. He is today's guest of honor. Professor Ridwanur Rahman sir, he has completed his MD, MBBS from Chittagong Medical College, and he has completed his fellowship FCPS in internal medicine. Professor Ridwanur Rahman has made a significant contribution to clinical research in Bangladesh, particularly in the field of malaria and Kalajor. He was the principal investigator of a clinical trial on combination treatment on visceral leishmaniasis, and he also co-authored many original papers. He was the ex-professor and head of the Department of Medicine, Sohrawardi Medical College, and now he is working as head of research, Universal Medical College and Research Center. And Dr. Nazmul Hassan, he has done his MBBS from Chittagong Medical College, from the same medical college from where Professor Ridwan has passed, and followed by MD in cardiology and MRCP from UK. He is the youngest fellow of the European Society of Cardiology and working as an assistant professor of cardiology of Ad-Din Medical College Hospital. Now we can start today's webinar. Ridwan sir, would you like to say anything else, or shall we proceed?
No, thank you very much. I welcome you all, and I must thank the organizers for inviting me to be in the meeting. I personally have metabolic syndrome, so my family also has. So I'll be listening to the very expert presenter, and I will invite all of you to come to the same tune and listen to the lecture. Thank you very much.
Okay, thank you, Professor Ridwan sir. So now we can start our lecture. So I think that this will be a wonderful and brilliant lecture by Professor Raman Puri. So I would request Professor Raman Puri to start his lecture. His topic is overall management of dyslipidemia.
Thank you, Dr. Soeb, for inviting me for this presentation. I'll share my slides. Is my slides visible?
Yeah, it's visible now.
Okay. So I'm going to discuss about dyslipidemia, the management overview of 2021. We all know that LDL cholesterol, there is a positive linear relationship between LDL cholesterol and coronary artery disease, and based upon a lot of data from epidemiological studies, RCTs, randomized Mendelian randomization studies, and familial hypercholesterolemia, natural history, we all know that it is no more a risk factor. It has a causal relationship with ASCVD. LDL cholesterol has been the target since 1988, and initially it was less than 130 milligram in patients with high risk group. It was brought down to less than 100 in 1993 based upon CARE trial, and then it was brought down to less than 70 milligram based upon PROVE-IT TIMI22 trial. And even European guidelines also recommended LDL cholesterol less than 70 in their guideline published in 2011. Then in 2013, American ACC came out with recommendation that there is no need to target LDL cholesterol, and they identified 4 group of patients in which moderate to high intensity statin was advised. These guidelines had a strong impact in CVD mortality in United States. You can see there was a significant decline in CVD mortality from 2000 to 2010. Recently, it has gone up slightly because of increase in incidence of metabolic syndrome. Not only in USA, even in European country, there was a significant decline, more than 50%. And if you look into the CVD mortality in India, it has gone up by 41%. From 1990 to 2051. And there are a number of reasons for it. And one of the reasons is this: when I talk of Indians, basically it is a South Asian community I'm talking about. And since these expert consensus was published, which was published last November 2020. So whatever I'm presenting is the recommendations which we published in 2020. One of the reasons behind increased prevalence of coronary artery disease in Indians, Asians, South Asians are increased prevalence of atherogenic dyslipidemia. That is, if the lipid abnormality in the form of normal or mildly raised LDL cholesterol, high triglyceride, low HDL cholesterol, and high prevalence of small LDL particle. This is not the only factor. There are other reasons also, like we have increased central abdominal adiposity, and we develop risk factors at a much younger age. And we have a poor control of ASCVD risk factors. The most important thing is that we have a poor awareness about CVD and primordial prevention. And our dietary pattern is like we take a lot of ghee, butter, and oily trans fats. So that may be one of the reasons for increase in coronary artery disease in South Asians. And so this is a matter of concern that the CVD mortality has gone down in European country, in America, and it has gone up by 42%. And also, as far as statistics in Bangladesh is concerned, from the rural Bangladesh, one study shows that the CVD mortality increased by 30-fold from 1986 to 2006 in male, and about 47-fold in females. And in another study, it was found that the abnormality in lipoprotein was again predominantly increase in triglycerides, low HDL in 75% of the patients, and about triglyceride was increased in 48.5% of the secretariat employed in Dhaka who are involved in this study. That is again what exactly we said about atherogenic dyslipidemia is high triglyceride and low HDL cholesterol. Now, this is a recently published study in which the lipid lipoprotein abnormalities was compared between India population and United States. You can see that the total cholesterol is significantly lower in Indian as compared to Americans. LDL cholesterol is also significantly lower. Triglyceride is significantly higher. HDL is significantly lower. Non-HDL cholesterol is lower, and ApoB is higher in Indians as compared to those subjects of United States. And according to Interheart study, when South Asians were compared with other countries, we can see the ApoB to ApoA1 ratio was significantly higher in South Asian population as compared to other countries. And as you know that most of the ApoB are carried by LDL cholesterol, LDL particles, and ApoA is carried by the HDL particle. So this shows that we have higher ApoB to ApoA ratio in Indian because of much lower ApoA, much lower HDL cholesterol in Indian population or South Asian population. And this ApoB to ApoA ratio is significant because it again is positively and linearly related to CVD mortality. Higher is the ratio, greater is the CVD events or CVD mortality. So therefore, we need our own recommendations. LAI came out with expert consensus statement in 2016 with an objective to reduce cardiovascular morbidity and mortality in India and also in the South Asian country. This was published in JAPI in 2016. We were the first country in the world to recommend LDL cholesterol target of less than 50 milligram in patients with very high risk group and patients of established coronary artery disease or cerebrovascular disease or peripheral artery disease are included in very high risk group. And non-HDL cholesterol is 30 milligram more than LDL cholesterol. LDL cholesterol was considered as the primary target according to our expert consensus statement, part 1, and non-HDL cholesterol was considered as co-primary target, means it was as important as the LDL cholesterol target was. In the same year, 4 months later, European guidelines were published and they recommended LDL cholesterol of less than 70 milligram in patients with documented cerebrovascular disease. This made our task a bit difficult because they recommended 70 and we recommended 50, but we were able to convince our doctors that the real target should be less than 50 rather than less than 70. Our target was based upon a strong scientific evidence, and if you look into one of the meta-analysis of 8 statin trial, you can see that if those patients who achieved LDL cholesterol between 75 to 110 and as compared to those who achieved LDL cholesterol less than 50, there was 19% reduction in major cardiovascular event. And subsequently, Improve IT trial was published in 2015. Here, these were the post-ACS patients, 18,000, and with simvastatin 40 milligram, the LDL cholesterol achieved was 69.9, and with ezetimibe and simvastatin, the mean LDL cholesterol achieved was 53. And this difference of 69.9 to 53.2 reflected in 6% reduction in events, So this means lowering LDL cholesterol down from 70 to 50 resulted in further reduction in cardiovascular events. And again, in 2015, these are the 2 PCSK9 trial, again that revealed that lowering LDL cholesterol down to less than 50 milligram resulted in about 50% reduction in cardiovascular event. In 2019, European guidelines came out with new recommendations. In this recommendation, they lowered the LDL cholesterol target from 70 to 55 milligram in patients with ASCVD. And that is what we recommended in 2016. Now, if we look into the patients with Improve IT trial, in which I just told you that there was a 6% relative risk reduction in event when LDL cholesterol was reduced from 70 to 50. Even at 53 milligram of LDL cholesterol, 32.7% of the patient had cardiovascular events. And another trial was the Odyssey outcome trial. Here also 12.5% of patients had events despite the mean LDL cholesterol achieved of around 53. Now, what are these subset of patients who are having events despite achieving, mean LDL cholesterol of 53? And what are the baseline characteristics of these patients, which makes them prone to have cardiovascular events, even if you bring total LDL cholesterol to 53, which is quite an aggressive LDL cholesterol lowering. And another important aspect was which came to our mind is that does this patient have still LDL cholesterol residual burden? So that if we reduce LDL cholesterol down from 53 to 30 milligram, would it decrease cardiovascular event further? So with these 3 ideas, we had about 19 meetings in 13 cities in which we involved 162 experts. and we published 2 important documents. So this document, first document was published in Journal of Clinical Lipidology in month of March 2020, and second was in the form of expert consensus statement, a part 3, which was published in November, and Dr. Soeb is also one of the author of this paper. Now, in this, we modified the ASCVD risk algorithm of 2016, in which we categorized patients into 4 risk groups. Here, we added another risk group, which is an extreme risk group. Now, the 4 risk groups are low risk group, which is based upon major ASCVD risk factors. If there is no major ASCVD risk factor or one ASCVD risk factor, patient falls into low risk group. If the patient has 2 major ASCVD risk factor, he falls into moderate risk group. Those who have 3 or more major ASCVD risk factor, he is in high risk group. And in very high risk group, as I said before, that patients with pre-existing ASCVD, patients of diabetes with 2 or more major ASCVD risk factor, or diabetes with target organ damage, or patients of homozygous familial hypercholesterolemia. These risk factors we published in 2016. And in 2020, we added a new category, which was a extreme risk group. And this extreme risk group, we further divided into category A and category B. Why we created extreme risk group, I will discuss in my subsequent slide. This category A was those patients of coronary artery disease who have 1 or more features of high risk group, and category B are those patients of coronary artery disease who have 1 or more features of very high risk group, or recurrent ACS despite mean LDL cholesterol of less than 50 milligram, and those patients with polyvascular disease. Also, in place of metabolic syndrome, we added 4 moderate risk non-conventional risk factors, those with impaired fasting glucose, increased waist circumference, apolipoprotein B more than or equal to 110 milligram, and high sensitivity CRP of more than 2 milligram per liter. It's a very simple risk algorithm. It doesn't require any computer, doesn't require internet. If you have this table with you, you can classify your patient into one of this ASCVD risk group. In this, and the target of LDL cholesterol in extreme risk group, in category A, we recommended LDL cholesterol less than 50, which is similar to very high risk group, which we recommended in 2016, but we created an optional goal of less than or equal to 30 milligram. But in category B, we recommended LDL cholesterol goal of less than or equal to 30 milligram. Now, question comes that why we created this extreme risk group? What is the justification of this extreme risk group creation? Now, these are 9 independent clinical indicators. These are the clinical conditions. If they are present in patients with coronary artery disease, they increases the incidence of increased cardiovascular event at any level of basal LDL cholesterol. Whatever the level of LDL cholesterol is there, if 1 or more of these conditions are present, the cardiovascular event will go up. Now, if I apply these clinical indicators in patients in TRA secondary prevention TIMI-50 trial, in which patients of stable ischemic heart disease or previous myocardial infarction were included, you can see here that if none of these risk indicator is present, the 3 years MACE is only 3.5%. Means the 3.5% of this patient had events in 3 years. As the number of this risk indicator goes up, the incidence of cardiovascular event goes up. And if it is more than 7, the incidence goes up to 58.6% in 3 years' time. So you cannot keep all patients of coronary artery disease in one group, because associated comorbidities increases the risk of future cardiovascular event. Now, if I apply these indicator in patients with improved IT trial, which I discussed before, I can classify patients into 3 risk groups. 1, those who have 3 or more risk indicator along with coronary artery disease, they are in high risk group. And those patients of coronary artery disease with no risk indicator or 1 risk indicator, it falls into low risk group. And if the patient of coronary artery disease have 2 of these risk indicator, it falls into intermediate risk group. Now you can see here that the blue bar is achieved LDL cholesterol of 69, and this orange bar is the mean LDL cholesterol of 53. So these are the events at achieved LDL cholesterol of 53. You can see patients of coronary artery disease, 14% of these patients had event achieved LDL cholesterol of 53 as compared to 34% in those patients of coronary artery disease who have 3 or more of this risk indicator. Again, showing that as the number of these comorbidities increases, the risk of cardiovascular event increases. Now, we all know that patients of coronary artery disease falls into very high risk group based upon our 2016 recommendation. So expert felt that those patients who are in high risk group, who have 34% events at achieved LDL cholesterol of 53, should be treated as an extreme risk group category B, and intermediate group of patients should be taken as an extreme risk group category A. Now, if in Odyssey outcome trial, you can see that those patients of coronary artery disease, means single vascular bed, the events were 8.6%. With this blue again, rectangular bar is achieved LDL cholesterol 53.3. At 53.3 milligram of achieved LDL cholesterol, 8.6% of these patients had events in 3 years' time. And in those patients of coronary artery disease with cerebrovascular disease or peripheral artery disease, it went up to 20.3%. And those patients of coronary artery disease plus cerebrovascular disease plus peripheral artery disease, it went up to 26.7%. Just see, from single vascular bed, events increased twice in 2 vascular bed, and it increased to thrice time in 3 vascular bed involvement. So this means patients of coronary artery disease, depending upon comorbidities, behave differently. So they are in a different group, so they cannot have the same goal. Now, in Fourier trial, patients achieved mean LDL cholesterol of 30 milligram. Even those who achieved LDL cholesterol of 30 milligram, those patients of coronary artery disease who have more than 5 of these risk indicators, still 15.5% of patients had event, as compared to those patients of coronary artery disease who didn't have any of this risk indicator or only one, which was only 3.8%. So see, 4 times more events in patients who have more of these comorbidities. Now, this is a very interesting trial in patients with acute myocardial infarction who underwent PTCA. Adverse event was followed up for 1 year. You can see that patients of coronary artery disease, events were in hospital outcome, 6 months outcome, and 12 months outcome. You can see that patients who have only coronary artery disease, 12 months outcome was only 5.5%. It increased to 8.1% in patients with coronary artery disease and hypertension, increased to 15.6% in patients with coronary artery plus and diabetes, and it went to 18.7% in patients who had coronary artery disease, diabetes, and hypertension. So from all these, the studies which I have told you, one thing is very clear, that all patients of coronary artery disease cannot be grouped into one group. They cannot have the same goal of LDL cholesterol, like a goal of less than 50 milligram according to LAI recommendation and less than 55 according to European recommendation. So there was a need to create an extreme risk group category A and B. So that was the basis of how we created this risk category A and B, which is unique again in a sense that no international guideline has classified extreme risk group category A and B in their recommendations so far. Now, coming to the target of 30 milligram, as I said that in extreme risk group category B, we gave the target of less than 30 milligram. So now, what are the basis for this 30 milligram? From where this number 30 milligram has come? This is based upon, again, strong scientific evidence, and this is based upon randomized control trial, Fourier trial. And if you look into the Fourier trial, the basal LDL cholesterol median was 93, and it was brought down to 30 milligram with the addition of PCSK9 over and above maximum lipid lowering drug. We can see there was a 15% reduction in primary endpoint and 20% reduction in the secondary endpoint. And there are 2 important meta-analyses. One is the statin trial, meta-analysis, another is a non-statin trial meta-analysis. In statin trial meta-analysis, it was seen that if basal LDL cholesterol is less than 70 and we reduce it to less than 30 milligram, there was 37% reduction in event. In non-statin trial meta-analysis, again, reducing LDL cholesterol from 63 down to 21 milligram, there was 22% reduction in event. Again, showing that lowering LDL cholesterol to below 30 milligram, there was significant reduction in events. Then there are three important post-hoc analyses. One is the Odyssey outcome trial post-hoc analysis, in which about 2,000 patients had of placebo with the mean LDL cholesterol of 73 was compared with those patients who achieved LDL cholesterol of less than 15 milligram, which was about 730 patients. So reducing LDL cholesterol from 73 to 15 milligram, there was 29% reduction in events. In IMPROVE-IT trial, in those patients who, about 6% of patients achieved LDL cholesterol less than 30 milligram, here, as compared to more than 70, there was 21% reduction in events. And in Fourier trial, there were 2,000 patients who had median LDL cholesterol of 66. When it was brought down to 21, there was about 30% reduction in events. So all these post-hoc analysis shows that lowering LDL cholesterol down to below 30 milligram from basal LDL cholesterol of 70 and above, there was significant reduction in events. Now, these were all event-driven trials. If you look into the imaging trial, this is a reversal trial in which 80 milligram of atorvastatin was compared with 40 milligram of pravastatin. And with intravascular ultrasound, total atheroma volume was seen. Here you can see in pravastatin, the mean LDL cholesterol achieved was 110. With achieved LDL cholesterol of 110, there was progression of atheroma by 2.7%. And those patients who were given 80 milligram of atorvastatin, the LDL cholesterol mean was 79, and there was 0.4% decrease in total atheroma volume. Though it is not significant, we can very safely say that there was no significant progression. And if we look into the GLEVCO trial, in which 93 milligram was compared with achieved LDL cholesterol of less than 30, you can see there was insignificant progression at 93, and there is highly significant regression in patients who achieved LDL cholesterol less than 30 milligram. So we have discussed about event-driven trial. We have seen the imaging trial also, that again shows that lowering LDL cholesterol down to 30 milligram results in regression of atheroma also, and reduction in cardiovascular event also. We have been using statin for almost 3 decades now. It's a very safe drug, and there are some controversies which we can of course discuss, but it's one of the safest drugs in a sense that it does reduces total mortality by 10% and coronary artery disease mortality by 20%. And even azitamide we have been using for almost 2 decades now. It is a very safe drug because we have used this drug for about 7 years in IMPROVE-IT trial without without any significant adverse effect because of azitamide. Or even in this trial, we can very safely say that 6% of patients who achieved LDL cholesterol of less than 30 milligram, there was no significant adverse effect as compared to those who achieved LDL cholesterol of more than 70 milligram. Now we have 5 years PCSK9 OSLER-1 open label avelumab study. That again shows that giving PCSK9 for 5 years or more, there are no adverse effect either because of a lower LDL cholesterol or because of PCSK9 inhibitor. So based upon whatever I have discussed, there is a strong scientific evidence of benefit of CV reduction if we reduce LDL cholesterol to less than 30 milligram in some subset of patients. And there are no significant adverse effect either due to lipid lowering drug or because of LDL cholesterol less than 30 milligram. So now coming to the justification of lower LDL cholesterol in Indians, and these are some of the points that despite following Americans and European guidelines, we still have progression. We develop heart disease 10 years earlier than Americans, and 25% of those dying of coronary artery disease are less than 40 years of age. Coronary artery disease is more severe and it takes a malignant course, and mean LDL cholesterol in Indian is at a lower as compared to Americans, and even ACC now considers South Asian as a ethnicity as one of the risk enhancer, And if we have shown that if we reduce LDL cholesterol to less than 30 milligram, it does reduces cardiovascular event, and we have lipid abnormality, atherogenic dyslipidemia, which is quite prevalent in our country and a South Asian country. This is a comparison of LAI, European and ACC guidelines. It is what ACC recommends in patients with ASCVD. If there are no comorbidity, they say just give high intensity statin. Whereas European guidelines says less than 55, we recommend less than 50 milligram. Those with recurrent ACS, American guidelines says that if LDL cholesterol is more than 70 despite high intensity statin and ezetimibe, you add PCSK9 inhibitor. European guidelines says you bring down LDL cholesterol to less than 40 milligram. From where this number 40 has come, I have failed to find out from the literature. I'm not able to justify this 40. But we have enough evidence of less than 30 milligram, whatever I have discussed so far. Now, those patients of ASCVD with associated comorbidities, American ACC guidelines says that you add PCSK9 inhibitor if LDL cholesterol is more than equal to 70 milligram. This is almost similar to what we have said, because if your patient's LDL is 80 milligram with high intensity statin and ezetimibe, and if I add PCSK9 inhibitor, the LDL cholesterol will come down to around 30 milligram. There are no such in European guidelines, whereas we have categorized into category A and B, and we have given an optional goal of less than 30 in category A and goal of less than 30 milligram in category B. There are no international guidelines which classify extreme risk group into category A and B except Lipid Association of India guidelines. Now coming to the most important part is triglyceride, which requires a lot of discussion, because whether it should be treated or not. It was the ATP3 in 2001 which gave the recommendation of triglyceride less than 150 milligram as normal, and they suggested that if triglyceride is more than 500 milligrams, you should treat it first to prevent pancreatitis, and they also recommended non-HDL cholesterol as a secondary target. Now, in our latest, and in 2017, according to our publication, we recommended less than 100 milligram of LDL cholesterol as the optimal goal of triglyceride lowering in Asian, South Asian population. This is a recent publication of 2020, according to which whenever patient comes to you, whether he comes in fasting or non-fasting, you take his sample, because we require both fasting lipid profile and non-fasting lipid profile. Because fasting lipid profile is important to us, because LDL cholesterol is our primary target. It will tell us whether the patient has achieved the target or not, and it will also help us to judge that whether patient is is taking the drug or not. And non-fasting lipid profile is important, is because we have high prevalence of triglyceride. And it has been well documented by various studies now that non-fasting hypertriglyceridemia is one of the factors which is responsible for increase in coronary artery disease. And if you look into patients of coronary artery disease, you will find that non-fasting triglyceride will be high. So this is an important for us. So for Indian population or South Asian population, you should always have fasting lipid profile and non-fasting lipid profile. And even if fasting lipid profile is normal, even then you should go for non-fasting, because there can be abnormal response to the food, and normally it should be less than 175 milligram per deciliter. If it is more than 175, then it is considered as a postprandial hypertriglyceridemia. This is our algorithm. How should we treat patients of hypertriglyceridemia in patients less than 400 milligram, 500 milligram? Our main objective is to reduce coronary artery disease, and one should calculate ASCVD risk. But before we start thinking of treating triglyceride, lifestyle intervention is extremely important. And second important thing is to rule out the secondary cause for any, if any, which is responsible for high triglyceride, like alcoholism is one, nephrotic syndrome is one. There are many conditions which increases triglyceride. So you should rule out secondary cause, because if you treat them like diabetes, the triglyceride level will come down. So lifestyle intervention is extremely important for any level of triglyceride. But if the triglyceride is less than 500, you should always treat these patients initially with statin plus minus azitamide. Try to achieve LDL cholesterol goal. And if you have achieved LDL cholesterol goal and still triglyceride is high and non-HDL cholesterol is high, one can consider omega-3 fatty acid or fibrate. And in those patients who have triglyceride more than 500, our main objective is to prevent pancreatitis along with lifestyle intervention. But you can simultaneously start statin or ezetimibe if the patient falls into high risk group or very high risk group. And if the patient is still not responding to all the treatment of triglyceride lowering drug, then this may be a genetic disorder where genetic test may be required. And we have now newer drugs which are coming up which can reduce, which is the antisense agents and small interfering RNAs, which can reduce triglyceride by about 75 to 80%. But most important thing is that you achieve LDL cholesterol target, non-HDL cholesterol target, and ApoB target. If you achieve all these targets, I tell you, you have done the best for the patient as far as their lipid management is concerned. But remember, when you are treating these triglyceride and LDL, make sure that patients' other modifiable risk factors are also taken care of. You should control his blood pressure, you should control his diabetes, he should stop smoking, and he should do regular exercise. Both fasting and these are recommendations are important for managing this. Try to maintain triglyceride below 150 milligram and preferably less than 100 milligram. Now coming to non-HDL cholesterol. Non-HDL cholesterol is the cholesterol present in all atherogenic atherogenic particle. Atherogenic particles are those particles which carries ApoB, and these are chylomicron remnant, VLDL remnant, intermediate density lipoprotein, LDL particles, and apoprotein small a. So non-HDL contains LDL particle plus other atherogenic particle. So it is total cholesterol minus HDL cholesterol is non-HDL cholesterol. So this is why this is very important, because when we are treating LDL cholesterol, we are just targeting the LDL cholesterol, which of course constitutes about 80 to 85% of the cholesterol carried by the total cholesterol, and remaining about 15% is carried by the other triglyceride-rich lipoprotein particles, which is also to be treated, because it has been found that these remnant cholesterol present in this target in triglyceride-rich lipoprotein carries the same atherogenic potential as the LDL particle is. Now, the importance of non-HDL cholesterol you can have from this statin trials meta-analysis. Here, those patients who have LDL cholesterol of less than 100 milligram, but non-HDL cholesterol more than 130 milligram, they have 32% higher risk of cardiovascular event as compared to those patients who have LDL cholesterol more than 100 milligram and non-HDL cholesterol of less than 130 milligram, which is just 2%. So increase in non-HDL cholesterol, irrespective of LDL cholesterol, is associated with higher cardiovascular events. And LDI recommends non-HDL cholesterol as a co-primary target. It is as important as LDL cholesterol for lowering lipid lowering treatment. And in all patients, non-HDL cholesterol should be kept within 30 milligram of LDL cholesterol values. Now coming to apolipoprotein B as a predictor for CVD, as I said, there are two type of lipoprotein particles circulating in our blood. One is an atherogenic particle, which is responsible for initiating atherosclerosis, and it is responsible for progression of atherosclerosis. And other is anti-atherogenic particle, which is an HDL particle, which carries cholesterol from the tissue to the liver. So it is said to be protective, and this is said to be, harmful in a sense that it initiate and cause progression of atherosclerosis. All these atherogenic particles are VLDL particles, which carries ApoB 100, intermediate density lipoprotein, and LDL particles, and also other particles are chylomicron and chylomicron remnant, which carries ApoB48. This is a Swedish studies, Emory study. This is one of the largest study, 25 years follow-up of 175,000 patients, individuals. It was seen that the ApoB is a stronger or better predictor of future myocardial infarction as compared to non-HDL cholesterol and as compared to LDL cholesterol, in which 98,000 were men and about 76,000 were women. And one of the meta-analysis of 12 epidemiological studies, this was published in 2011. It was found that one standard deviation increment of ApoB increases relative risk of events by 43% as compared to one standard deviation increase of non-HDL cholesterol, which increases by 34%, and as compared to LDL cholesterol, which increases by 25%. That shows that it is a better predictor of future cardiovascular, ApoB is a better predictor of future cardiovascular event as compared to non-HDL cholesterol and LDL cholesterol. And this is the same study in which it was found that if we, over 10 years period, a non-HDL strategy would prevent 300,000 more events than LDL cholesterol strategy. And ApoB strategy means if you take the ApoB as a target, would prevent 500,000 more events than a non-HDL cholesterol target. So this means if we take ApoB strategy in the treatment of patients of ASCVD, and it will prevent 800,000 patients as compared to LDL cholesterol strategy. So this means it is a better, target as compared to non-HDL cholesterol, and it is definitely a better target as compared to LDL cholesterol strategy. We have recommended in our 2020 guidelines that those patients with extreme risk group category A should have a ApoB level of less than 65, and in extreme risk group category B, the target of ApoB should be less than 50 milligram. Now, those in our latest publications, we have included ApoB of more than 110 milligram as a moderate non-conventional risk factors. This corresponds to about more than 110 milligram of LDL, 130 milligram of LDL cholesterol. What does it mean? That if a patient of low risk group has an ApoB more than 110, it is reclassified as a moderate risk group. And if a moderate risk group of patient has ApoB more than 110, it is reclassified. A higher group means a high risk group. So this is a moderate non-conventional risk factor. Again, we are the only guidelines which have given importance of ApoB as a moderate non-conventional risk factor. And it is preferable to estimate ApoB to assess ASCVD risk in patient with diabetes, metabolic syndrome, obesity, high triglyceride concentration, or very low LDL cholesterol. But it is recommended in high risk patients once we have achieved LDL cholesterol and non-HDL cholesterol goal, because if the patients still have, even after achieving LDL cholesterol goal and non-HDL cholesterol goal, if the patients still have high ApoB, then we have to further intensify the treatment to bring down the ApoB to the target value. So this means then we don't have to look into the LDL cholesterol C target value or non-HDL cholesterol value. We have to look into the ApoB, level in patients, especially patients of very high risk group and extreme risk group. And it is recommended in patients of diabetes with in diagnosis of type 3 hyperlipoproteinemia. Now, these are the recommendations for high sensitive CRP. It is this time we have included this as a moderate risk non-conventional risk factor, though it is not directly involved in atherosclerosis, but it is a risk marker. To use it as a risk stratification tool, at least 2 reading 2 to 3 weeks apart should be obtained. That is extremely important. And why it is important, as I have said, in ApoB more than 110, it benefit in reclassifying a moderate risk group. It doesn't help in reclassifying low risk group, but its importance is in a moderate risk group. If it is high, then you can classify this patient into high risk group, and if it is low, then patient can be classified as a low risk group. And it is important in post-ACS patient because those patients who have high sensitive CRP, high after 4 weeks of ACS, they carry higher chances of future cardiovascular event. So we have to be more aggressive in management of risk factors, and we should lower LDL cholesterol to the target which LAI has recommended in their 2020 recommendations. Now coming to the lipoprotein small a, this is a particle which resembles LDL particle, but it differs from LDL particle. It is an LDL because it carries along with it ApoA. So this is an LDL cholesterol particle which is attached to ApoA, and it has been seen that the concentration in the blood of lipoprotein A is genetically influenced. You can't change it with a dietary management or lifestyle management, and it remains static throughout lifetime. And so therefore we have recommended in our recent recommendation that you should always include lipoprotein A whenever you are doing the lipid profile of your patient. Preferably it should be done at the age 18. It has been seen that for each 50 milligram increase in lipoprotein small a, the risk for ischemic stroke goes up by 20%, and also this is based upon observation studies and in the genetic studies. And if you look into top 10 percentile value of lipoprotein A and compare with bottom 10% lipoprotein value, high top 10% lipoprotein value carries 2 to 3 to 4 fold higher risk of myocardial infarction as compared to bottom 10 percentile value of lipoprotein A. It has 2 to 3 times more chances of aortic stenosis, 1.6 to 1.8% chances of heart failure, and also ischemic stroke and the mortality. Now, LPA, according to LAI recommendations, at the time of initial screening of subject 18 years of age, we should definitely include lipoprotein small a, especially in those patients who have a family history of familial hypercholesterolemia or premature ASCVD. Then we have recommended the lipoprotein A assessment in patients with premature ASCVD, patients with familial hypercholesterolemia, a family history of premature CVD and or elevated lipoprotein small a, and recurrent ASCVD despite optimal lipid lowering treatment. And it is very important to assess in patients after ACS and also in those patients who are not responding to the maximum lipid lowering drug, because there are no drug other than PCSK9 which lowers lipoprotein A. Rather, with statin there is increase in lipoprotein A by 5 to 10%. And it should be estimated in patients with ischemic stroke with uncertain etiology, and those patients with calcified aortic valve stenosis, and those who are undergoing TAVI. So these are some of the recommendations, latest recommendation of Lipid Association as far as lipoprotein A is concerned. Now, finally, coming out with the lifestyle recommendation of 2020 by Lipid Association, in the diet, we have emphasized that there should be liberal intake of vegetable, fruit, whole grain, low-fat dairy product, poultry, fish, and legumes. And non-tropical vegetable oils, we have recommended that we should give choice number 1 to mustard oil or groundnut oil, and we do not recommend coconut oil, and we also are not we recommend saturated fat. Butters and ghee can be taken in a moderate quantity but should not be taken in an excess amount. And we should limit intake of sweets and sugar and sugar sweetened beverages and meat. And of course, we should have Mediterranean and Indo-Mediterranean diet, because this Mediterranean diet has shown that it reduces mortality by 30% in one of the trial. We do not recommend alcohol, especially in Asians, because in inter-heart study it has shown that alcohol doesn't protect Asians from myocardial infarction. Rather, there can be slight increase. Physical activity is extremely important because inactivity is associated with cardiovascular coronary artery disease. We should walk at least 150 minutes per week with moderate intensity, or 75 minutes per week with vigorous intensity aerobic physical activity or combination. What we should do is that we should walk, for a layman talk, we should walk about 5 kilometers in 45 minutes every day. That is said to be a good moderate intensity walk. That's a brisk walk. And aerobic activity can be performed in an episode of 10 minutes, 3 times a day. If you are not able to get the time for about half an hour to 45 minutes, you can break it down for at least 10 minutes duration. And we should always go for a muscle strengthening activity. That is important because with old age, there is definitely sarcopenia as you lose muscles as the age advances. We do not recommend any tobacco product. And of course, we do recommend yoga and stress management. Yoga is a supplement to physical activity. It cannot replace physical activity, and one should also have a adequate sleep. Is also to be encouraged. At least 6 to 7 hours in a day, one should have a proper sleep. Thank you very much for your kind attention.
Thank you, Professor Raman Puri, sir, for your excellent and brilliant lecture. Yes, through his lecture, we have known that not only the LDL is the culprit then for the development of atherosclerotic cardiovascular events or major adverse cardiovascular events, but also the triglyceride, the non-HDL, and the apolipoprotein AOP. There are multiple factors which are responsible for the development of the major adverse cardiovascular events. So from the audience, I have seen some of the questions that in the chat box. I would like to put these questions towards our guest, Professor Puri. So one of the questions was that there are multiple questions, but one of the questions is, which one do you prefer regarding the atorvastatin and rosuvastatin? Because in our country, these two drugs are available and these are relatively economic. Simvastatin and other lipid-lowering agents are possibly less common or less available in our country. So in our country perspective, which one should we prefer? Which one is your recommendation regarding atorvastatin and rosuvastatin?
Now, coming to the difference between two drugs, I don't find you can use any one of these 80 milligram of atorvastatin or 40 milligram of rosuvastatin. It's of your choice. But if you look into the Saturn trial, in which high intensity statin atorvastatin was compared with 80 milligram was compared with 40 milligram of rosuvastatin, it was found that the regression was significantly more in patients with 40 milligram of rosuvastatin as compared to 80 milligram of atorva, and also there was significantly greater increase in HDL cholesterol in rosuvastatin as compared to atorvastatin, and the LDL cholesterol lowering was significantly more with 40 milligram of rosuvastatin versus 80 milligram. The difference, of course, is about 5 to 6%. The 80 milligram of atorvastatin on average reduces LDL cholesterol by 50%, and rosuvastatin reduces it by about 55%. So in patients with extreme risk group category A and B and a very high risk group, if you ask me, I will definitely go with the rosuvastatin 40 milligram, because we get the maximum lipid lowering of 55 with rosuvastatin as compared to 50 milligram with atorvastatin. But again, it is individual choice. If you are comfortable with 80 milligram of atorvastatin, that is equally good.
Okay, thank you, sir. There's another question that is, the question was put on that. The ACC recommend to start triglyceride lowering therapy if the TG is more than 1000. But the ATP recommends to start TG lowering drug if the triglyceride is more than 500. So, which one is your suggestion for the South Asian perspective to start the TG lowering therapy? Which cutoff value?
Yeah, this time in our expert consensus meeting, we discussed this point quite frequently. But expert felt that since Asians have high triglyceride, it is better not to play unsafe, and it is better to bring down the triglyceride if it is more than 500 to prevent pancreatitis, because pancreatitis is a life-threatening disease and leads to a lot of complication, especially like diabetes. So it is better to bring it down with fibrates or omega fatty acid based upon reduced trial, icosapent ethyl ester, if it is available. So far, it is not available with us. I don't think that there should be any doubt in starting, because there are no significant adverse effect with fibrates. There are no significant adverse with omega-3 fatty acid, icosapent ethyl ester. Why should we play unsafe with the patient when 500 to 1000 is concerned? So expert felt that it should be, the level should be taken as 500, not 1000. We should treat for pancreatitis if the triglyceride is more than 500 milligram to prevent pancreatitis,
Okay, thank you, sir. Another doctor, she has shared a scenario. Basically, the scenario is regarding her father. She told that my father, 54 years old, obese, diabetic patient, having HbA1c 6.5, and he is on regular treatment with metformin. His lipid profile is triglyceride 591, total cholesterol 315, LDL cholesterol 181, HDL cholesterol 46, HGPT 63, and ultrasonogram revealed fatty liver disease. The serum creatinine was normal and thyroid profile was normal. What should be his management approach? Should I be concerned regarding the raised HGPT during giving the statins?
I think that your father falls into high risk group as based upon ASCVD risk algorithm of LI is concerned, and his LDL cholesterol should not be more than 70 milligram, which is 181 milligram. That is extremely very high. I don't know how long he has been diabetic and how long this LDL cholesterol value is. So the most important thing is that you should start high intensity statin immediately with either 80 milligram of atorvastatin or 40 milligram of rosuvastatin, because reducing LDL from 181 to 70 milligram means you require more than 50% reduction in LDL. So I will definitely prefer rosuvastatin because it is 55% reduction. He may require azetamide if he is not a very good responder to statin. So first of all, you should trying to bring down the LDL cholesterol, but lifestyle intervention is extremely important for him because he's obese, he's diabetic. Triglyceride which is raised is possibly not because of uncontrolled diabetes, because his HbA1c is 6.3%. I don't know whether he takes alcohol or not. So try to find out other potential risk factor for increase in triglyceride. But for your father, it's very extremely important to have a regular exercise. Should lose weight and bring down the LDL cholesterol. In case there is a good aggressive lowering of LDL cholesterol, you have the time to reduce the dose subsequently because the target is less than 70 milligram. Number two is that it is better to rule out subclinical atherosclerosis by going for either coronary artery calcium score or CT coronary angiography because of very high values of LDL cholesterol. Number three, it looks to be that there may be a possibility of genetic dyslipidemia because total cholesterol is very high. So family history will be very important about his father or brothers, any one of them, or I think you should also have your lipid profile so that there is if it is a genetic inheritance, heterozygous familial hypercholesterolemia, then many family members will be having hypertriglyceridemia also. Now coming to the SGOT-PT, if it is it doesn't go more than 3 times, you should not worry about it. And I think that benefit is of using statin is far more than potential adverse effect of increased SGOT, SGPT. So I think that you should be very aggressive in bringing down LDL cholesterol to the target which we have recommended. But most important part is lifestyle intervention and rule out other cause for high triglyceride.
Okay, thank you, sir. Is there any concern regarding is there any concern or any the question is another: is there any target goal of LDL in fatty liver disease?
Now, see, there is a concern among physicians that if SGOT-PT is raised and patient has fatty liver, whether to start statin in patient with dyslipidemia or not. That's a very big concern because of increase in SGOT-PT. Remember one thing, that in these patients, in dyslipidemia, it has seen that there are not a very strong prospective RCTs which proves it, that even there is a decrease in SGOT-PT when you start statin in patients who have dyslipidemia, and especially those patients who have coronary artery disease when statin is given. And one should not worry about increase in SGOT-PT or increase SGOT-PT if it is less than 3 times the upper value of normal. Should not be a criteria. You have to calculate the risk versus benefit. If, for example, patient is in a very high risk group or extreme risk group, or patient who's diabetes, as I've discussed just now, then you should monitor LFT. Nowadays, we do not monitor LFT. Only one value may be good enough. After that, I have never done in my patients who are on statin, high intensive statin for many years, because it doesn't show any hepatotoxicity at all. But of course, after starting, before starting statin, if the SGOT-PT is raised, if it is not raised more than 3 times or 4 times, because if it is raised 3 times or 4 times, you should rule out active, hepatitis or chronic, hepatitis that has to be ruled out, in which possibly you can stop or you can withhold the statin for some time till the liver recovers. But once SGOT-PT comes down, you can safely start statin, and it should not be a factor for not starting statin if statin is justified or if statin is recommended for the patient to reduce future cardiovascular event. It should not be a matter of concern, because very, very rare hepatotoxicity have been reported. Should not worry at all.
Okay, thank you. Another scenario has been shared by another doctor. A 30-year-old young male, non-smoker, non-alcoholic, with moderate physical activity. His LDL cholesterol was 130, HDL 32, no family history of diabetes or Cbd. Does physical exercise is enough for him, or does he require any drug for lowering the LDL level?
See, if you look into this patient, he has one major ASCVD risk factor, because he has low HDL, and his ApoB, if he with LDL cholesterol of 130, will be more than 110. So he falls into moderate risk group, ASCVD risk group. There is no harm in giving a trial of 3 to 6 months for bringing down LDL cholesterol to less than 100 milligrams. That is our target as far as our risk algorithm is concerned. You can give it safely for 6 months, but after 6 months, if LDL cholesterol is still high, more than 100, you can start with statin, a small dose of statin. But when you start statin in this group of patients, it has to be a shared decision, because you have to discuss with the patient why you are starting this, what are the basis of you are starting recommending statin is this, what are the evidence of showing benefit, and what are the potential adverse effect which has been reported, which can be a matter of concern to the family member. But without shared decision, statin should not be started in 30 years person. Now, there can be another scenario. In this, for example, a patient's LDL is 130 with HDL cholesterol of 40 milligram, this means there is no ASCVD risk factor, because none of this fact. Here you should calculate lifetime risk assessment. If it can be calculated by JBS3 risk algorithm or calculator. And if you do not have internet, then there is a Lloyd Joint Framingham risk algorithm. That is again is a chart where you can calculate that what is your lifetime. Lifetime means up to 80 years. What is your chance of having a cardiovascular event? If with absolutely normal, factors, say Cbd risk factor, no hypertension, no diabetes. If lifetime risk score is more than 30%, remember, if it is more than 30%, means you have 30% chances of having a cardiovascular event by the time you become 80-year-old. Then here again you should classify these patients as a moderate risk group, and again the same strategy, 3 months to 6 months lifestyle intervention, aggressive lifestyle intervention, and if the LDL cholesterol is still more than 100, you can start small dose of statin, of course with a shared decision. And only thing which you have to really watch is that, is the patient really doing aggressive lifestyle intervention or not? Because it is the most difficult, part of the treatment. How should we trust patient or not? But point is this, that we have to believe patient sometimes, and there are no other parameter by which you can assess whether patient is following proper lifestyle intervention or not. But taking a high risk of cardiovascular risk in Asian, South Asians, and coronary artery disease is more diffuse. It takes a malignant course. It carries a higher mortality. It is always best to have LDL cholesterol below target, which we have recommended. And the best level of LDL cholesterol is 70 milligram, because if you keep 70 milligram, neither there will be deposit of LDL particle, nor there will be regression. So whatever is the status of artery will remain like that. So if there are no atheroma, there won't be any atheroma. And if there is atheroma, it will not progress. It will not regress, but it will not progress. So physiological level of LDL cholesterol is 70 milligram. But of course, in patients in low risk group or moderate risk group, our objective is not to bring down LDL cholesterol to less than 70 milligram with statin. But if it is LDL is more than 100 milligram, then our target is to bring down below 100 milligram with statin, but not to 70 milligram in patients with low to moderate risk group. But if with a lifestyle intervention you can bring it down to 70 milligram, then we will definitely recommend that, because with the lifestyle intervention with exercise, you do have increase in HDL cholesterol, which is a physiological HDL cholesterol, which is said to be protective, cardioprotective. Any HDL which is increased by pharmacotherapy has not shown any benefit, based upon AIM-HIGH trial and HPS2 Thrive trial, in which rather there were more of morbidities associated with these drugs. So therefore, exercise is extremely important, but try to achieve LDL cholesterol, the target which we have given in our recommendations, both 2016 and 2020.
Okay, thank you. There is only last question. I think we cannot allow, because time constraint, we cannot allow further questions. The last question is there any concern regarding the target of very low LDL cholesterol? Because some are concerned regarding the development of diabetes or depression, very low LDL cholesterol. So is there any concern regarding, or any serious adverse effects with very low LDL cholesterol?
First of all, I'll just tell you that every tissue of our body is able to make cholesterol as per its own requirement. Number one, every cell has LDL receptors, and it can make cholesterol with the same process which liver makes. Each cell can make. You take adrenal gland or ovary or brain, whatever it may be, they make sufficient cholesterol. Number two, the brain doesn't require LDL cholesterol from the LDL particle. It has its de novo synthesis. It has our own mechanism. So even if circulating LDL cholesterol is very low, it is not going to affect brain metabolism, because it has a pathway. It's a different process by which it makes its own LDL cholesterol. These two things, when you understand, that shows that cholesterol from the LDL particle, and every tissue in our body can make cholesterol as per its own requirement. So lowering LDL cholesterol to 30 milligram or to a lower value will not lead to more of adverse effect. And this has been seen even in Fourier Trial, in which 2% of patients achieved LDL cholesterol less than 10 milligram with median of 7 milligram, in which there was no significant increase in hemorrhagic stroke, there was no significant increase in cognitive dysfunction, there was no significant increase in diabetes. And as far as hemorrhagic stroke, which I think is written there, has been a bit a controversial, topic, because in Sparkle trial, which was published in 2006, there were 68% increase in hemorrhagic stroke in the trial, and it was seen that these hemorrhagic stroke was increased in those patients who were enrolled with history of hemorrhagic stroke in the past. So 2% of the population had a prior history of hemorrhagic stroke. So as such, Odyssey trial, in which LDL cholesterol of less than 15 was there, Improve-IT trial, in which LDL cholesterol of less than 30 milligram, Fourier trial, CTT analysis, Jupiter trial, in which there were about 700 patients who achieved LDL cholesterol. There was no significant adverse effect because of low LDL cholesterol. So I think you should not worry about that. But if some patient had a prior stroke with hemorrhagic stroke, then you should be a bit cautious, otherwise not.
Okay, thank you, sir. I think that we have come to the end of our question and answer session. So it is the time for the comments from our panel of experts. So I would like to request put some important comments of today's lecture or repeat by Dr. Nadul Hassan.
Thank you very much for inviting me in this nice scientific program. And I would like to thanks to Professor Raman Puri for his excellent presentation regarding the overview of management of hyperlipidemia. All of you know that the atherosclerotic cardiovascular disease exert a significant impact on mortality and morbidity throughout the world. And we got to know that the dyslipidemia, it is not an independent risk factor, it is more than that. That means it has a causal relationship with the development of atherosclerotic cardiovascular disease. And I think our today's lecture will guide us to treatment of. I would like to dig out some information from our today's presentation, that when we will do the in our day-to-day practice, when we will do the advise the lipid profile for a patient. And there are some conditions we know. If there is no comorbidity, we will advise it patient in male patient after 40 years, or in case of female patient after 50 years, or in case of postmenopausal female, in patient with diabetes, in patient with chronic kidney disease, with hypertension, those who are smoker, and sometimes in case of some chronic inflammatory disorder also, like rheumatoid arthritis, systemic lupus erythematosus, and some like psoriasis, this autoimmune disease. And we can do it in obese patient. From the guideline, we got to know that the patient with waist circumference in case of South Asian people, if in case of male more than 90 centimeter, in case of female more than 80 centimeter, patient with family history of premature death, and patient with family history of familial dyslipidemia. And we also got to know that we can do it. We can do the random serum lipid profile. And previously we knew that we will do the fasting lipid profile, especially when we have to know about the triglyceride level, and in some cases when we have to do the fasting blood sugar level. In that condition, we have to do the fasting lipid profile. But right now, from today's lecture, we can also do the random lipid profile in case of to see the treatment response and like extent of morbidity in case of hypertriglyceridemia also. And finally, after doing the investigation, we categorize the patient into some risk, those who are extreme risk, very high risk, moderate risk, and low risk. So we got to know that we have another group, that extreme risk factor. In like other chronic disease like diabetes mellitus and hypertension, when we are going to treat the hyperlipidemia, we have to keep in mind that other than our drug treatment, we will enforce the patient to adhere with the lifestyle factors, and we also look for the proper treatment of other comorbidity. Like in case of very high risk patient, those patients are their lifetime risk factor, Framingham risk factor, or there are also other comorbidity or established cardiovascular disease. Even our cardiology practice, we are using a very high in case of patient with acute coronary syndrome. to reduce the mortality and morbidity. Regarding statin, I would like to say that statin is not a drug. It is more than the drug, because in our cardiovascular history, we have few revolutions to reduce the mortality and morbidity of patients. The first revolution was introduction of CCU, which after introduction of CCU, we had able to reduce the mortality significantly. Then another revolution was introduction of statin. It is a revolution in the history of cardiovascular disease, because statin is we are not using statin not only to reduce the lipid level. Sometimes it acts as an antiplatelet effect. It has some angiogenic effects. So it has so many effects. So statin is not like a drug. It is more than the drug. Another important things for our cardiologist, we are using statin, high dose statin before the PCI also, because if we use the high dose statin before the PCI, so it reducing the major adverse effect related to PCI, like it reduces the post MI related to PCI, arrhythmia, death, and other mortality. So if we advise the patient, if we categorize the patient, and if we introduce the lipid lowering drug along with the lifestyle and treatment of the other comorbidity, we think we can just reduce the mortality and morbidity of our people, because we are very much concerned regarding the COVID, because you know that the mortality and morbidity related to atherosclerotic cardiovascular disease many fold greater than the COVID. So I think if we got a good idea regarding the treatment option and regarding the how we can manage a case of dyslipidemia in inpatient and outpatient department, I think we'll able to manage the dyslipidemia properly, and we can get a good life for the patients and for the society. Thank you very much. Thank you very much, Professor Yadurur sir, Professor Raman Puri, and Dr. Shoaib Mujumdar as well, and all the participants. Thank you very much.
Thanks, Dr. Nazmul Hasan, sir. Dr. Nazmul Hasan. So I would like to, we have come towards the end of this program. So I would like to come to Professor Ridwan Rahman, sir. He is the guest of honor of today's session. So I would like to request Professor Ridwan Rahman, sir, to pass his valuable comments.
Thank you very much, Dr. Shoaib. I am privileged and grateful and honored to be here today. And for that, I would like to thank the organizers. And more importantly, it was very pleasant to listen to Professor Raman Puri. It was such an excellent presentation that we could listen to one of the makers of expert opinion on recommendation for managing lipids. And I personally is a National Technical Committee member for NCD prevention and control. So what I would like to thank Professor Raman Puri is that today he has done a big thing for the NCD prevention and control. As you know that NCD means all diseases which are not communicable, all are NCDs. But there are identified 4 major NCDs by WHO, which are causing 80% of the deaths out of the more than 2/3 dying from non-communicable diseases. So we had an epidemiological shift, converting from more deaths from communicable diseases. Now we have 2/3 of the deaths are coming from non-communicable diseases. And cardiovascular diseases is the most important of the major cardiovascular diseases, which are killing people of premature age. That means less than 70 years is premature death. So the SDG targets that they will reduce 25% of these premature deaths by the year 2030. So this target cannot be achieved without preventing primary prevention for atherosclerotic cardiovascular disease. So today's topic was gave such an outline. I won't say is an overview. I would say is an in-depth discussion on the basis for recommendations. So he not only read out the recommendations, he, as an expert, described the basis for the recommendations, such that the listeners became uniform on the reasons for setting some targets. So we say that the chronic diseases should have a plan of categorizing risks and interventions which can reduce the incidence of cardiovascular disease in addition to the treatment. So this risk algorithm will require screening of the patients of all population above the age of 40, as he has very rightly shown, that we are genetically predisposed to dyslipidemias, all forms of dyslipidemia. And recently, because of the socioeconomic transition, the food habit, work habit, exercise habit, all has been modified in the Indian subcontinent. So despite having low body weight, it is said that, but the fat is very high. The triglyceride in many patients are very, very high in the Indian subcontinent. So addressing the dyslipidemia in a comprehensive way can reduce this premature cardiovascular disease death. And both India and Bangladesh have almost similar risk factors, similar socioeconomic transition, similar lifestyle transition, similar epidemiological transition. All this combined, that this lecture will be most useful to the intellectuals who wants to learn and teach and train my healthcare workers, such that we can optimally utilize the recommendations for managing lipids, which is one component of the major cardiovascular risk factor, cardiovascular diseases. So in addressing risk factors, we need to understand that we need to address all the risk factors together, rather than only addressing one component of the risk factor. As well as we need to incorporate lifestyle modification into addressing the major risk factors to prevent Cbd developing. And that there is enormous evidence here shown that we can reduce the risk. We can reduce the risk significantly with currently available interventions. So we need to be addressing the issues of screening, issues of treatment, issues of monitoring, and all these are based on individual risk calculations for predicting future cardiovascular disease. So the individual risk calculation is important. He has very rightly highlighted. We need to calculate individual risk and categorize every individual above 40, or we can lower it to 30, that they have accumulated risk calculated to address the lipid in preventing atherosclerotic cardiovascular disease. So he has very rightly, very nicely brought out the contributions of LDL-C, HDL, non-HDL, triglycerides, and ApoB as a non-traditional, non-conventional risk factors. I think it was very illuminating lecture, and that we can also, and also the contributions of Nazmul Hussain, who very rightly discussed some of the points. So I don't want to go into further details because time is already quite long. I would like to stop. And before stopping, I'd like to invite the listeners that we need to join the movement, a movement to reduce premature cardiovascular deaths. We have confirmed evidence-based recommendations for reducing Cbd, and we need to adopt that if we want to achieve the SDG target. Thank you very much. Thank you for patient hearing.
Thank you, Professor Raman sir, for his in-depth discussion and thought-provoking comments. So I think that LA is leading the movement. So I think that with the Bangladeshi doctors will also the lead in this movement to curtail the cardiovascular risk and to prevent, to raise a war against dyslipidemia and dyslipidemia associated premature deaths. So thank you. I would like to thank Professor Puri. Sir, would you like to tell anything else?
Thank you very much, Dr. Saib, for inviting me. And I'm sure that you all will practice the recommendations I have suggested. And we should prevent premature coronary artery disease, as rightly told by Dr. Raman, that our focus should be on that. And these guidelines which we have are not guidelines, these expert consensus statement we have really with the motive of reducing cardiovascular morbidity and mortality. And once again, thanks to you for giving me an opportunity to be among all of you.
Thank you, sir. So with this, and I will also express my gratitude to Professor Raman Puri, sir, because her daughter left for the USA this night. In spite of beating her in the airport, he remained at home to attend this webinar. So it indicates that he has a great passion for educational events. So again, I would like to express my thanks from my core of my heart for attending and joining this event and making this event great. And also to Professor Raman sir for joining as a guest of honor, and Dr. Nagunasan and all the participants. So with these few words, I would like to conclude this session. Thank you, everybody. Good night. Have a good night.
Thank you.
Assalamu alaikum and good night, everybody.
Thank you.
Okay.